Sexually transmitted diseases, henceforth called STDs, includes urethritis, cervicitis, pelvic inflammatory disease, henceforth called PID, syphilis, condylomata acuminata, pediculosis, which is crabs, and scabies. How do we answer the question, what is the most likely diagnosis? Because urethritis and cystitis both give you dysuria, frequency, and burning. That is to say, frequency, urgency, burning, and dysuria are in common between both disorders. However, cystitis does not give you a discharge. For urethritis and diagnostic tests, the best initial test is the urethral swab for gram stain and white cells. Now, that's for men only, that it's the most accurate test right now. And what you're looking for is intracellular gram-negative diplococci, which basically is Neisseria gonorrhea. It's always been that way. That's old standard and quite correct because it's the only way you can tell this instant while the person's with you in the office or clinic. The most accurate test is urine, voided urine. Now, this is very important. Don't let this slip you by. That the significance of that it's a urine test. It doesn't need a physician, doesn't even really need healthcare work. You'd say pee into this cup, and the urine for nucleic acid amplification detects gonorrhea and chlamydia. The nucleic acid amplification is a DNA probe. That is the most accurate test. And that extends markedly your ability to screen lots of people. And this is one of those neat things where it's both better for the patient because it's much more comfortable. A urethral swab is very uncomfortable. And more accurate and better for society too because it's less expensive than having to go see the doctor. Other causes of urethritis are Mycoplasma genitalium, ureaplasma, ureolyticum, and in women, women can do a self-administered vaginal swab. Wow, again, a great opportunity, much easier. Treatment is a combination of one drug for gonorrhea and one drug for chlamydia. Quinolones aren't the best initial therapy anymore because of resistance. The STDs have been passing around between each other, something dirty. They've been tossing around a plasmid because the plasmid between the STD is kind of like a STD, really. They've been tossing around something that's been getting around to everybody and making things difficult, a plasmid. And because of resistance, we're going to use for gonorrhea cefixime, which is a oral third-generation cephalosporin, and ceftriaxone, which is an intramuscular. That's what we use it here in STDs. We use it intramuscularly, intravenously for most other things. The reason why azithromycin is so easy is because it's one single dose orally of azithromycin and doxycycline. So the treatment, one gonorrhea drug and one chlamydia drug. Now that means it can be cefixime and azithromycin, or ceftriaxone and azithromycin, or ceftriaxone and azithromycin, as long as you just have one from the column on the left and one from the column on the right. And this goes for both men and women as the initial therapy. Cervicitis is an infection of the cervix. It means that it's not a vaginitis. That's a very precise term because vaginitis is very different. Vaginitis is not gonorrhea and chlamydia. Vaginitis implies extra bacteria or protozoans like Trichomonas growing in the vaginal vault. Cervicitis always implies an STD. It is one that causes an inflamed or strawberry cervix on speculum examination. And the testing and treatment are identical to what we just said for urethritis, which is, except you can use a self-administered vaginal swab for the nucleic acid amplification test. Now, it's a big deal. Again, don't let it slip you by. If it says, which should seem better, which is the gynecologist does a speculum exam and gets in there and quite precisely places the swab in the cervix, sounds like it's more accurate, doesn't it? But it's not. Ma'am, hi, would you be so kind as to take this swab and to apply it inside your vagina, put it in until it doesn't go up anymore, and you do it very gently and just put it in this container and leave it for the nurse at the desk. Thank you so much for coming. Pelvic inflammatory disease, cervicitis, and urethritis are all caused by the same bugs, which is to say gonorrhea, chlamydia, and that's why the treatment for urethritis and cervicitis are 100% identical. Single dose cefixime or ceftriaxone, single dose azithromycin, or a week or two's worth of doxycycline, one gonorrhea drug, one chlamydia drug. Pelvic inflammatory disease adds a little bit more because there's the possibility of pelvic anaerobes, and it presents with lower abdominal tenderness and lower abdominal pain, fever, well, says the infectious disease section, cervical motion tenderness, which can only be found on physical examination with bimanual examination, two hands, and white count up is often found. Not essential, not essential, not essential, but often found. You don't have to do blood for a white cell count, but it's contributory. So the question will say, a woman comes in with lower abdominal tenderness and lower abdominal pain, cervical motion tenderness. What is the next best step? What is the most appropriate action at this time? Now, when they say action, step, and do, does it mean a test or a treatment? In this case, it means always exclude pregnancy first and don't believe sexual histories. Once you've excluded a pregnancy as a cause of the lower abdominal pain and tenderness, you might say, well, how can just a pregnancy do that? Well, it's not the pregnancy that would do that. It would be the ectopic pregnancy that would cause the pain, fever, tender, even white count. If it's the ectopic pregnancy or the ruptured one, the most specific tests for pelvic inflammatory disease is a cervical swab for culture, DNA probe for nucleic acid amplification testing, and these tests will clarify the need for treating the partner. That's one of the reasons to do them. If you're going to treat both anyway, why bother testing? The answer is one, to confirm what the person has. Number two, you need to be able to treat the partner and also to be able to chase it down through the community. Culture is preferred for the gonorrhea, because the only way to be sure what the sensitivity is of the gonorrhea is with culture. That's the only way. We don't have a genetic testing way for gonorrhea and chlamydia to determine resistance. We have it for HIV. We have genotyping for HIV, where you could do it on just one single blood test, but this kind of test is not available for gonorrhea. Now, cervical testing isn't the most accurate test for PID. Ooh, that's a surprise for a lot of people. Cervical testing, such as cervical swab and stain and culture, DNA probe, is not the single most accurate. The single most accurate is. The most accurate is laparoscopy. It's only rarely needed, but it is the answer to the question, what's the most accurate? It's rather like doing a tympanocentesis or sinus biopsy in someone who has otitis media or sinusitis. Laparoscopy is the answer if and only if the diagnosis is unclear, the symptoms persist despite therapy, or there's recurrent episodes. It is certainly not done routinely. It is not even done in a significant minority. It's not even done in 10 or 15%. It's done very rarely for those people who don't respond to therapy or simply keep coming back. Why does it keep coming back? Maybe that wasn't the diagnosis. Laparoscopy. For pelvic inflammatory disease, we're going to use a combination of medications for chlamydia and gonorrhea. And this is very similar to what we said for urethritis and cervicitis, but for inpatients, it's slightly different. Cefoxitin or cefotetan is combined with doxycycline. Now, this indication is the only time you're going to ever hear us say that there's a quite specific indication for cefoxitin or cefotetan. These two drugs don't have a specific indication for anything else except this, meaning that, well, ceftriaxone is a drug of choice for community-acquired pneumonia. Ceftriaxone is a drug of choice for meningitis, and there are a lot of things like that. But here, because these are the only two cephalosporins that cover anaerobes, we use it for more severe PID because more severe PID has pelvic anaerobes. Outpatients, which is felt not to be as definitively with pelvic anaerobes, can be ceftriaxone and doxycycline. So you see that the major issue is going longer in therapy. That's why instead of single dose azithromycin, we're going to use doxycycline. And sometimes the outpatient therapy is metronidazole to cover, again, those pelvic anaerobes, metronidazole anaerobes. Now, sometimes students who have anxiety problems will think, wow, what if they ask you to choose ceftriaxone and doxycycline or ceftriaxone, doxycycline, and metronidazole? Wow, which one do I choose? Well, it's not like that. You don't get asked to choose things where they're both potentially right. That's just not rational thinking. That's not how it goes. If there's anaphylaxis to penicillin, remember, if there's a rash, you can use the cephalosporin. If there's a rash, you could use the cephalosporin. But anaphylaxis, meaning hypotension, tachycardia, breathlessness, use levofloxacin, metronidazole as an outpatient, or clindamycin and gentamicin as an inpatient. And remember, only anaphylaxis. Ulcerative genital disease. How do I answer what is the most likely diagnosis? Well, it's often impossible to determine the specific diagnostic or visual characteristics that are going to allow you to answer that question. And if they want you to know the answer, they have to tell you something, period. The question has to have sufficient evidence to give an answer. All genital ulcers have inguinal adenopathy. And if all they say is it's an ulcer with adenopathy, no one would know what the answer is. If the history and physical describe a painless ulcer, often described as heaped up indurated edges, the most likely diagnosis is syphilis. And if instead it says a painful ulcer, soft and painful, it is chancroid. Chancroid, which is Haemophilus ducreyi, or ay 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 ay, it hurts me, I do cry. If the lymph nodes are tender and suppurating means they actually burst with pus or purulent material, the most likely diagnosis is lymphogranuloma venereum. Now, why don't you look at that presentation? Lymph nodes, problem mostly? Lymphogranuloma venereum. Ooh, lymph nodes, lympho. Vesicles prior to the ulcer, and they're painful, is herpes. And when herpes loses its vesicles because they're in the genital area, rubs up against things, and the roofs come off. And the roofs come off, and it's just an ulcer. You can't actually answer what is the most likely diagnosis until you do further testing, such as the Zank prep. What is the diagnosis and most accurate diagnostic test? For syphilis as a diagnosis, the best initial test is the dark field. Now, this is the only way to be nearly 100% sensitive in primary syphilis. The VDRL or RPR are only 75% sensitive. There's a 25% false negative rate on these. You need time for the body to develop a response, and that is not going to happen in primary syphilis in 1 in 4 people. That's a huge miss. So dark field microscopy is the only way to be sure. FTA or MHATP, fluorescent treponemal antibody, or the microhemagglutination assay for treponema pallidum. Wow, that's long words, isn't there? These are used to confirm things, but they're delayed. So don't let people fool you by saying, well, we don't do that. It doesn't matter what you do or don't do. What's the most accurate test? The most accurate test in primary is a dark field. Chancroid, which is a Haemophilus, because it's a Haemophilus, you can see it on a stain. Now, it may need a special culture, but since it is a Haemophilus, you can see it as a pleomorphic gram-negative coccobacillus. Pleomorphic gram-negative coccobacillus means somewhere between a coccyx and a rod. Lymphogranuloma venereum is caused by chlamydia, and since chlamydia is not visible on a gram stain, since it's intracellular, since chlamydia does not grow in regular culture medium because it's intracellular and blood agar doesn't have cells, since it's not seen in gram stain or regular culture media, you have to use special non-culture methods such as complement fixation titers, serology, nucleic acid testing, DNA probes. Herpes simplex, the best initial test is the Zank prep. The Zank prep is like it's like a pap smear, honestly. You swab the lesion, you take up cells, you see multinucleated giant cells. Now, the Zank prep will not allow you to tell the difference between herpes 1 and herpes 2. As a matter of fact, it doesn't even allow you to tell the difference between herpes 1, herpes 2, and varicella. But in terms of treatment, well, it doesn't really matter whether it's herpes 1 or herpes 2 because they're all going to get acyclovir, famciclovir, valacyclovir anyway, and it's available instantly. Now, the most accurate test is a viral culture. This may be hard for some of you to grasp that we actually do culture for viruses, but we do. We don't do it a lot, but for herpes is a fast grower. And actually, it'll grow like 2 to 3 days, just as a regular bacterial culture would. And it's certainly the most accurate test. Now, it may not grow in regular bacterial blood agar, but it will grow in a cell line culture. You take some cells, plate them out, you throw the virus in there, and if the virus is in there, you can tell it makes the cells misshapen in 48 hours. Really easy. The dark field exam is certainly the most accurate test of primary syphilis. And if the dark field is positive for spirochetes, no further testing for syphilis is necessary. The dark field has such tremendous specificity that no further testing for syphilis is needed, because once you actually see organism, it is far more specific than indirect tests like an FTA or VDRL. Treatment for syphilis, as it was in the beginning and will be for a long time, the best initial therapy for both primary and secondary syphilis is one single intramuscular shot of benzathine penicillin. And benzathine is just a longer acting version of penicillin. Doxycycline if you're penicillin allergic, doxycycline for primary and secondary syphilis. For chancroid, we will use a single dose of azithromycin orally, very easy. Lymphogranuloma venereum, because it is a chlamydia, LGV, can be treated with doxycycline because it's a chlamydia. It goes longer because it's more deep-seated. Herpes simplex is going to be treated with acyclovir, valacyclovir, or famciclovir, and they are identical in efficacy. For those who have recurrent treatment, and develop resistant acyclovir-resistant herpes, which can be detected on viral sensitivity testing, the therapy is foscarnet, which works through a different mechanism of action. It does not work through thymidine kinase. The most common wrong answer in that one is to say ganciclovir. And ganciclovir is a drug that works through thymidine kinase too. If you're resistant to acyclovir, you'll be resistant to ganciclovir too. So therefore you got to use foscarnet. A woman comes to clinic with multiple painful genital vesicles. What is that next best step? What do you do? Do you treat? Do you test? And the answer is straight to treatment. When you have clear genital vesicles, you should go straight to oral acyclovir. Topical acyclovir simply isn't effective. Matter of fact, it's so ineffective as to be worthless. And I don't use that word lightly. It has the same efficacy as placebo. Remember, step 2 does test route of administration. Zinc prep is not necessary if the presentation is diagnostic. Testing is not necessary if the presentation is diagnostic. Testing is not necessary. The same answer applies to viral culture. Although it is the most accurate test, it's not necessary if the vesicles are clear and obvious. Serology is worthless because it can't distinguish genital infection from oral infections in the past. People make this mistake all the time. They think that getting serologic testing has any degree of specificity. It doesn't. 95% of the population is seropositive for herpes because if you had a cold sore from almost any form of human contact in the last 50 years, your IgG will be positive in your blood. It's worthless. PCR is what you do in a brain, not the genitals. That's for your head, not for your penis or your genitals. Primary syphilis presents with a painless genital ulcer with heaped up indurated edges. It becomes painful, it becomes secondarily infected with bacteria, and then you might say, well, how will they be able to tell the difference then? How will you be able to tell the difference from that in chancroid if it becomes painful? And the answer is, you can't, and neither can I. It has painless adenopathy. Well, what if it becomes painful? How do you tell the difference between that and LGV? Well, you can't. You see, my friends, if they want you to know the answer, they have to tell you something. And genital lesions are a perfect example of that. Chancres are gonna heal anyway, even without treatment. The penicillin may make it heal faster, but the penicillin is there predominantly to prevent later stages of the disease. That's why you're treating. It's very hard for people to realize that primary and even secondary syphilis resolves spontaneously. It's very hard to get that. Well, that's the fact. It does. And if you don't treat them, it resolves, and then it presents later on with secondary syphilis, which is palm and sole rash. Generalized, but often on the palms and soles. 2, alopecia areata. Areata means in areas, like patchy. Mucus patches. And alopecia areata means patches of hair loss, and mucus patches mean patches of mucus, usually on the mouth and genital lesions. Condylomata lata on the genital areas. Now, don't be confused that with the word condylomata acuminata. Condylomata lata is syphilis, and condylomata acuminata is papillomavirus. That's genital warts. Tertiary syphilis presents with heart problems, gummas, neurosyphilis. Which of the following is the most common? And the answer is neurosyphilis. Neurosyphilis could be a shriveled up general paretic brain. It could be vasculitis in a young person. So meningovascular means the meninges and the vascular system are inflamed. It used to be much more common, but it'll describe a person who has a stroke at a young age. When you see a stroke in a 35 and 40-year-old, wow, why did that happen? Even 45 or 50, why? Why a stroke at 35? Get a VDRL or RPR. Could have been syphilis. Tabes dorsalis is loss of position of vibratory sense with involvement of the posterior columns, like B12 deficiency. It's talked about quite a lot, so I'm sure this is one of the only things that people end up knowing when they go through classes like this. Incontinence and some cranial nerve abnormalities. In addition to the tabes dorsalis and the vasculitis causing strokes in a young person, the other presentations of neurosyphilis are general paresis. What does that mean? It means general weakness. It means your memory and personality change. It means your brain becomes the size of like a walnut by the time you die. It's really tiny. Or an Argyll-Robertson pupil, which is a pupil that will change with accommodation but won't react to light. It will change with accommodation, meaning when you look close at something, it will constrict, but it won't react to light. Aortitis, aortic regurgitation, aortic aneurysm, and gummas, which are skin and bone lesions where the skin and bone just break down. It's like a big ulcer or sore. Let's summarize the diagnostic testing of syphilis. For primary syphilis, the VDRL or RPR has a 75 to 80% sensitivity. A specific test of fluorescent treponemal antibody has a 95% sensitivity and specificity in primary syphilis. The secondary syphilis, the VDRL and RPR is essentially 100% sensitive and 100% specific. However, there's a tiny number of false negatives, but almost nothing for secondary syphilis. Tertiary syphilis, the VDRL and RPR have a 95% sensitivity, and the FDA is extremely specific. There are a lot of causes of false positive VDRLs and RPRs. This is a test that overreacts to other causes of antibodies being made in the body, such as infection, or just by being older, you accumulate a lot of previous injury and antibodies. Same way, just by being older, you get more false positive rheumatoid factors. Injection drug use, that's very common. AIDS, malaria. Antiphospholipids is especially important because the reagent in the VDRL is a phospholipid. So the antiphospholipid syndrome antibody simply reacts against the phospholipid in the test. And it's the same with anticardiolipin antibodies. The reagent in the VDRL is a cardiolipin. And endocarditis is a cause of chronic infection. Most people don't understand with endocarditis how many antibodies there are floating around there. It's a very common cause of false positive VDRL or RPR. It's a very common cause of the anemia of chronic disease, too, the endocarditis. But for false positives, titers are rarely above 1 to 8. Rarely above 1 to 8. When they're false positive, they're tiny, 1 to 1, 1 to 2, 1 to 4. A low titer is simply more often falsely positive, and high titers are rarely false positive. And can you say, you mean the higher the titer, the more likely it is to be real? Yes, the higher the titer, the more likely it is to be real. False positive ones are generally positive at very low titers. The treatment of primary and secondary syphilis is 1 single intramuscular shot of penicillin, oral doxycycline if you're penicillin allergic, and tertiary syphilis gets IV penicillin and desensitization if you're allergic. This is to remind you. Why am I saying this again? Because I don't want you answering desensitization for primary and secondary syphilis if you're penicillin allergic. That's for neuro and for pregnancy. The Jerisch-Herxheimer reaction is a febrile, uncomfortable reaction from the treatment of syphilis. When the organism dies, it releases antigens and pyrogens that simply make you briefly and temporarily uncomfortable. It has absolutely no danger to the patient whatsoever. It's just uncomfortable. You give them aspirin and antipyretics, and it'll pass. Make people comfortable. It's inflammatory. Give them anti-inflammatories. Desensitization is for neurosyphilis and pregnancy only. Genital warts, condylomata acuminata, is a papillomavirus. Well, lots of people have papillomavirus. Yeah, but they don't have the genital warts. It's based on basically you see them. You see those lumpy white things there. They're a little paler, and that's because you don't have the normal pigments, because it's just squamous cells. You see them. You don't need to biopsy. You don't need serology. You don't need stains, smears, cultures, aerial photography, satellite imagery. How do they look? They look like a wart. You got a wart. That's it, period. Same answer for molluscum contagiosum as well. The treatment of all warts, and not just condylomata acuminata, but molluscum contagiosum and common warts as well, is simply to remove it. And it's a bit like shaving or cutting your toenails, which is to say, in this case, just cryotherapy freezes them off, liquid nitrogen, very cold, freeze them off. Surgery for really large ones. Laser can sort of cut them off with laser, melt them off with podophyllin or trichloroacetic acid. And imiquimod is the only one that seems structurally different because, one, it's self-administered and applied locally by the patient, and it's an immunostimulant leading to sloughing off of a lesion, and you can't go too far. The problem with cryotherapy and laser and podophyllin is that the patients can experience some damage to surrounding tissue. It can hurt, can burn, it's uncomfortable. But imiquimod is very gentle, just slow. It's slow. How do I answer the diagnosis crabs? Well, you see it. You see it, little dark buggies there. You see those little dark buggies there hiding out amongst the trees of the hair in your pubic area and your axilla. It's itchy. It's visible on the surface, and you treat them with permethrin. Lindane is equally effective, but it's more toxic. Lindane basically is not toxic in normal use, but when people see this sort of thing, especially in their children, they start to go too far and like, oh my God, I got crabs! And they start putting it on 5 times a day. And toxicity causes seizures in children because if you start putting it on, it gets absorbed, then it does cause neurotoxicity. If both answers are in the choice, then there is a clear superior answer, permethrin. Because first we start with efficacy, then we go to adverse effects. And since both have equal efficacy and permethrin has less adverse effects, permethrin wins. Scabies are much smaller. They're tiny. It's like baby, scaby baby. And they dig in the web spaces between fingers and toes or at elbows, around nipples or near the genitals. And they burrow and they dig and they burrow and they dig. And they're smaller than pediculosis, literally 5 times smaller. And you have to scrape these guys out. See little arrows there pointing them. You got to scrape them out and magnify them. That's the only way to find them. They're too tiny to be seen. What we actually see is the burrows. And why you itch is because as they dig underneath you, they excrete poo-poo that causes you to react and it's sort of inflaming. Itchy, itchy, itchy because of reaction to the scabies stool. Therapy for scabies is permethrin, same as it is for crabs. Now we got one extra thing, widespread disease, often in immunocompromised people, sometimes called Norwegian scabies. Has to be treated with oral ivermectin. It's more efficacy. And this is severe disease and all patients need repeated dosing because what you do is you kill live ones and you come back a few days later and kill the larva. But oral ivermectin is for widespread crusted Norwegian scabies. And it will say widespread, it will say crusted, and it will often say an immunocompromised person.